Thanks, Tom. Thanks, Fernando. Thanks for being here. I have two jobs to do in the next 20 minutes. One is to try to help you understand why I think this idea of patient engagement, patient experience is important and what it is, and that it's a real thing. And two, show you some ways that I think we could make it better. So these ideas of patient activation and patient engagement are not something that we invented for this meeting. This is a very well-developed field that others have been thinking about for a really long time. They're slightly different. So patient activation is trying to make sure your patient understands their role in the care process. How much does your patient know about their disease, about what they should be doing, and about how they should be working with you? Patient engagement's a little differently. Patient engagement are the interventions that are designed to increase activation. So we want patients activated, but then patient engagement is something that we do to bring patients into their care to work with us and overall improve their quality of care. This isn't the same as adherence. You might say, well, a more engaged patient will be more adherent to their therapy, they'll do better. That's part of it, and that's a side effect of increasing patient activation and patient engagement, but it's not the emphasis of what we're talking about here. There are ways to measure patient activation, and I'll show you in a minute that if you can measure patient activation, you could actually show that those who are better activated will do better in their long-term care in other disease states and probably in inflammatory bowel disease. There are different levels that you can show in patient engagement. Level 1, to just show you some examples, says taking an active role in my own health care is the most important thing that affects my health. So that sounds like they're pretty activated, but actually all the patient is saying is they know it's important, but they're not actually necessarily doing anything to take that role. An example of something at level 2 is I know what each of my prescribed medications do. I would bet you, and you probably agree, that your patients wouldn't be able to answer that question in many circumstances for what their medications do and exactly what they're taking them for. But if they can get to that level, that's better than just simply saying, I know that it's important that I should be engaged. An example of something at level 3 is I know how to prevent problems with my health, what they can avoid, what they can do, what they can't do to make sure that they're taking some control over their own health care. And then getting to level 4 is something like, I am confident I can figure out solutions when new problems arise with my health care. Can they problem solve? Do they know who to call? Do they know what to do? Do they know when to go to the emergency room versus calling the nurse versus calling you and making sure they seek the right care? So you can see that it's easy to say that you want to be involved, but actually being involved is taking a much deeper ownership in their health care. So why do we care about this other than a measurement and just saying that it's important? Well, this has been looked at pretty well with better health outcomes in other disease states. So more activated patients adhere to treatment more. They perform disease monitoring more. You'll hear a lot about disease monitoring over the next couple of days, and we have to get our patients engaged and believe us as opposed to just giving them a lab slip and telling them to check their week 14 trough level. They're more likely to have normal BMIs, hemoglobin A1C, blood pressure, and cholesterol in other disease states, lower rates of substance abuse. And then less activated patients are 2 times more likely to delay medical care. Again, I'm sure you'll hear a lot about this over the next couple of days, but the longer we wait, the longer we delay for the multiple reasons that we and patients end up delaying their care, the probably slower will be to get their disease under control and increase complications of their Crohn's disease and ulcerative colitis. Why else is this important? Well, it leads to better healthcare experiences. So more activated patients report more positive care experiences. So just by simply engaging your patients more, they're going to report back that they've had a better experience with their care, and they have fewer problems with care coordination. Think of all the things we try to do and get our patients. It's hard taking care of these patients, but if we can get them as our partners, we're going to end up doing a lot better. This is interesting. Within the same provider, so this was a study done looking from provider to provider, but different patients within that provider, that patients who were more activated report better healthcare experiences compared to those who are less activated. So what does that tell us? It's not all about the provider, and it's not all about the experience that the provider's giving, but it's bringing the patient into it that will increase their positive experience. And if you're involved with this at your hospital, which is their CAP score, the Consumer Assessment and Healthcare Provider and Systems Survey, that many of our hospitals are very, very, very interested in now because of reimbursement, the scores are not just about providers. It's about what the patients say back, which is largely dependent on what their experience is of healthcare. Well, Healthcare costs, of course, have to be part of this equation. So more activated patients have been shown to have lower rates of hospitalization and fewer ED visits. You can look at the patient activation measure score. That's the score I showed you before with the different levels. And it's been pretty consistent that less activated patients have higher healthcare costs. So there are a couple of different reasons why we want to bring them into the equation here. And if that's not enough, if you've heard us talk about PQRS measures over the past couple years, well, guess what? That's changing again soon. And in 2015, CMS is now going to be looking at something different, which is the value-based payment modifier amount. This directly impacts our reimbursement. By 2017, we're all going to have to be dealing with this. And if you look at the components of this, it's not just about reporting quality metrics. It's about the patient experience, it's about care coordination, and it's about cost. So we need to think about this, but the good news is we can get our patients involved to help us as opposed to doing it all ourselves. So can we increase activation levels, or is this something that a patient just comes with and you say, well, too bad you're not activated. What can we do to make it better? Well, there are multiple interventions that have been shown to increase patient activation consistently to show improvement in these activation scores. And as I've shown you, higher activation scores, lower costs, better outcomes. They've shown improvements in quality of life, health outcomes as mentioned, objective clinical outcomes, adherence to treatment, reduce symptoms, reduce hospital readmission rates, and reduce use of the emergency department. So things that we can do have already been shown in other diseases to make these better. So how do we do this in IBD? Well, there are a couple of different ways we can approach this. First is engaging our patients in shared medical decisions and getting them involved. And I'll show you some work that we and others have done. Thinking about what their goals of therapy are, not our goals of therapy, not histologic healing, but what are our patients' goals of therapy? Developing tools so that they can be part of the decisions and decision aids, and then something that Gil Melman's already talked a little bit about today, this idea of partnership with patients. So shared decision making, if you're not too familiar with the term, is the process of interacting with patients who wish to be involved with their healthcare providers and making medical decisions. This isn't all patients. Patients come in all different varieties, and you know this when you're sitting in the office. You have patients who say, you know what, doc? Whatever you say, I'll do. These are my typical VA patient examples I use, where I love those guys. You can ask them to do something that's pretty much what they do, and they don't necessarily want to be involved. I know a gross generalization, but oftentimes, at least in my experience, fairly true. There are many patients that come in, and this is the opposite end of the spectrum, who they bring in the latest publications from the New England Journal of Medicine. They're reading about the microbiome and the genome, and they come in and essentially tell you what their care should be, which can be helpful at some point. Sometimes maybe they can be overly activated or overly engaged, but I find that those patients that in the past we would think were being more difficult or bringing information to us, oftentimes, many times, have great value that they're bringing to their care because you know that they're engaged and you know that you're going to be able to work with them and really have them be part of their care. But the type of patients that most people are is this collaborative role. They bring their preferences, they bring their knowledge, they bring their skills, but want your advice and our guidance in how to make decisions. If you ask patients in other disease states how often they want to be part of medical decision making, most of them do. About 80% of patients want to be part of their care. But about 20% of patients in other disease states, these were patients with RA and with diabetes, said that they would actually totally prefer the doctor to make decisions. So we have to sort that out. There's one of my colleagues at Dartmouth named Glenn Elwin, who is one of the world's experts in shared decision making, and he says when you're meeting with patients, one of the things you need to do is make a preference diagnosis, is how they want to be involved in their care, and that really can help you in your conversation with them to see how they want to be engaged, or is this something that they want to simply follow your lead, and that is going to happen in a certain amount of patients. In IBD, it's lower though, so this isn't a survey work that we presented over this past year at DDW, that almost 90% of patients had this overwhelming desire to be part of shared medical decisions. So it's going to be fairly unusual for IBD patients to say they don't want any part of it. They, in general, really want to be part of the decision making. Now, thinking about goals of therapy, and this is something that I've only really started to think about over the past year or two. Maybe I should have been thinking about this longer, and maybe you have as well. But we sit at these meetings and we argue over the definition of better. We talk about endoscopic healing, we talk about histologic healing, we talk about all different scoring systems for how to know that patients are better. And when we ask our patients, and I'm sure you've done this, of what they mean by better, they all have different answers for what they know and mean about when they're better. I've asked my patients frequently to send me pictures of things they do when they're better. And these are the type of things they talk about. They talk about getting back to skiing, about mountain climbing. That's a snow bike, by the way, on the bottom right-hand corner, which are pretty popular in New Hampshire these days. And there's my buddy Vern fishing. But patients have individual things that they know when they're better versus not better. And a patient in a focus group that we had a couple weeks ago really expressed this well. We were trying to define if there's some metric for remission. And he said, we all have different ones. For me, I can go to the movies. When I can go to the movies, that's when I feel better. If you asked me, Doc, when I came in, if I've been to the movies recently, and I said yes, I'm better. If I can't go, that means I can't sit through it. I can't even stand in line to get tickets. And that, for me, is my personal sign that I'm getting better. And I think we have to start thinking about individual goals of therapy a little bit more, as opposed to just indices that we might use to numerate if our patients are better or not. The other thing we've been working on is this idea of hierarchy of needs for the IBD patient. If this looks familiar at all, this is stolen, or not this, I redeveloped this for IBD, but this idea is stolen from the Maslow hierarchy of need. If you remember your Psychology 101 class in college, and what Maslow taught us is you can't think about the fine-tuning in life until you get the basics right. You need a place to live, you need your health, you need to be able to breathe, you need food. And only after you get that can you advance to the higher parts of this pyramid. So if you think about that for inflammatory bowel disease, we as doctors are focused on the top of this. We're doing scopes, we're doing imaging, we're watching their CRP. Well, I'm embarrassed to say that I definitely check more CRPs than I make sure that my patients can leave the house comfortably without having to wear diapers, that they're not incontinent during the day, that they're able to sleep through the night. Those are the things we need to be asking our patients at every visit, not necessarily being so fixated on every 3 or 4 month CRPs, with God knows what we do with all that information when we get it anyway. We started to ask patients this a little bit, of what their most important goals are in their care. And they just want to feel better. If you look up at the top, they want complete resolution of their symptoms. They don't want to be a little better. They want to feel completely better. They want to avoid ostomies. They certainly want to stay alive. And they want to not miss work or school. And they want to be able to achieve life goals. You know, Tom and Gil, our number one quality metric that we've always focused on is steroid-free remission. But, you know, patients said, hey, steroids are important, but they weren't anywhere near the top of what was most important to them. We know that we think this is important, but when we ask patients, they were more focused on just feeling better and just being able to get to work, as opposed to the very hard outcomes that we know are important, but necessarily aren't the most important things to them. So what are decision aids? Decision aids aren't a pamphlet that you give to a patient after you've prescribed a medication and said, read about this and let me know if you have questions. They're interventions that are developed to help patients make a shared medical decision. It's typically a presentation of evidence-based information in a patient-friendly format. Remember the way that we can get data. Remember the patients I told you bringing in publications from the New England Journal of Medicine. Those aren't decision aids, that's data and that's information. It's our job to try to distill that into something that can be very easy to understand for our patients. Again, this field isn't new. If you think about how many Cochrane analyses have been done in inflammatory bowel disease, I don't think there's a single one that has 86 randomized control trials to make the point. But in shared decision-making world, there are 86 randomized control trials that show that decision aids, tools to help engage and share medical decisions, are beneficial to patients. They can come in all different forms. You may have seen me show this before. This is a risk palette. This is a picture of what are meant to represent 10,000 patients with inflammatory bowel disease. I use this almost every day in the clinic when I'm talking to patients about their lymphoma risk. And instead of telling them that lymphoma is rare, which has various meanings to patients, or telling them that they shouldn't worry about it or that it's very unusual, I show them visually that in the background population in the United States, about 2 out of 10,000 patients over the course of a year will develop lymphoma just by bad luck without any medication exposure. However, with medication, whether it's monotherapy or combo therapy, I think a reasonable rate is around 6 or 9 out of 10,000 over the course of a year. And in sitting down with patients and showing this to them, I've had very few patients leave there frightened about lymphoma. They have a much better understanding of what the real risks are. You're not saying there's no risk, but you're putting it in absolute numbers and showing what I think is a fair representation of what we can talk to our patients. Another example is something called an option grid. This is online. And you can find this. This is a one-page description of side-by-side comparisons of immunomodulators versus anti-TNFs versus combination therapy. It gives evidence-based data about benefit and about the risks of these therapies, how they're administered, and it's something that you can print out and hand to your patients that's very easy. Parambir Dulai, who's here now, who's at UC San Diego working with Bill Sanborn, and I worked on an option grid for pediatric inflammatory bowel disease. If there are any pediatricians in the audience, that's available as well. Here are videos that we developed working with a great company called ME Solutions in Chicago. We work these out using evidence-based data, sitting in focus groups with patients, trying to really understand what they wanted to hear and what they wanted to learn about their disease and about treatment options. And I'm going to show you just 2 short clips. The Crohn's disease therapy one we developed a couple years ago, and we've been using now with great success in patients and also in a clinical trial setting. The UC version just finished over the past couple of weeks, and I'm happy to say that they're both available to all professional members of the CCFA. So Tom made a good plug for a lot of reasons you should become members of the CCFA if you're not. If you are a professional member, the phone number's there, or just call the main CCFA number and ask to talk to the professional services people. They'll send you a stack of codes, which are sign-on codes. You hand the codes to your patient like a prescription, and the patient could go on, sign in, watch it as many times as they want with their family, review it, ask questions, and there's a way for them to interact and print out questions that they have for their provider. So if you can just run that first clip for a few seconds, that'd be great.
Now, before we get into the details, I wanted to let you know, while medications can help prevent problems,
so this is
studies show that the medications we're talking about are more effective when people start taking them closer to the time they learn they have Crohn's and before problems develop. That's why your doctor may want you to think about using these medications now. Because once problems develop, they're very hard to fix or treat with medication.
All right, you can stop that one, please. So that goes on to go into all the different options, and we do get into this idea of early versus late treatment. And I would argue that that conversation could take you 2 hours in the office. This is about a 30-minute video that your patients can watch after the visit and then follow up with you, or maybe better yet, watch before the visit, before they come in and talk to you about these medications. Here's one that we just finished, worked with a number of great people. Mina Betra at Penn was helpful. Dr. Stefan Hullabar, who's a colorectal surgeon at Dartmouth with us, was helpful. We worked with a great group with Asher Kornbooth as well in the surgical options for UC section here. If you can run this just for a few seconds, that'd be great.
Now, I know you may be thinking, I could never get used to an ostomy, right? But once people have it, they realize they can travel, play sports, swim, and scuba dive. There are even professional athletes who have them. And while you may not plan to go pro, it's usually a big improvement in quality of life. So even if it's something you don't consider for many years, it's good to know most people are surprised by how much they like it. Okay, let's take a quick look at getting a J pouch.
So this goes in pretty good detail through the different surgical procedures, time for recovery,
and whether it can be
and
done
you can
with
stop that there. This goes into pretty good detail about the different surgical options for UC and actually plays up, I think, very fairly that surgery is an option at any point in their ulcerative colitis treatment. There's a second module that's being developed now that goes into much more detail about ulcerative colitis surgeries as well, and I hope from a year from now we'll be showing you that video and it'll be available to your patients as well. So this is my last slide, talking about this idea of partnership with patients. And Gil Melman mentioned this earlier. And if you're interested to hear more, please come and talk to Gil and I about this quality improvement collaborative learning health system that we're putting together. This is something we've been working on in the past number of years. The focus here has really started to change to take advantage of bringing patients into the equation, partnering with them, getting them engaged, and getting them part of their care in a much deeper way than they had been before. This is not a database project where we're going to go through charts, review what's happened to them, and report it out to PQRS. This is a project where we're going to be working very directly with patients, getting outcomes reported directly from them, and to help work with them in their care to do all these things that we talked about a little earlier. So to summarize, I hope I've convinced you that patient activation is a good thing. We have to think about this. This is a real thing, and we have to try to identify patients that are engaged, take advantage of it, or those patients who aren't, and how we can improve it. Patient activation leads to more than just engaged patients, but potentially better health outcomes and probably lower costs. We need to identify patients' personal treatment goals, not just our goals, but understand what they need really out of their care and help them focus on that, and they'll, I guarantee, be much more engaged if we do that. And then finally, decision aids can help engage patients, make better decisions, and ultimately improve their quality of life. So thank you again. If you're interested in getting these tools, if you're a quick work with your phone, you could scan my QR code here. All of the tools I showed you are accessed right there. Otherwise, let me know. I'd be happy to point you to our research site, and you could print out the risk palette, the option grids, and point you towards the other stuff as well. So thanks again, guys, and look forward to coming back to talk.